Pleasant morning to you all. I'm going to make a presentation on anatomy of the medulla. And for our learning objectives, by the end of this lecture, one should be able to describe the basic anatomy of the medulla, as well as explain general functions that are associated with the medulla, on top of actually being able to discuss the clinical implications that are there for specific localized lesions within the medulla. So, to begin with, this is a picture that is showing part of the brainstem, and this region here is actually going to be our medulla. Then rostral to it, that is going to be the pons and the midbrain in that region. So to make life easy, it's a bit fair to describe the medulla first, looking at its external features. Then after looking at the external features, we can then now describe the internal features of the medulla. So our medulla is going to begin at the foramen magnum as a continuation of the spinal cord, as one would like who could actually join the pons rostrally to the spinal cord inferiorly, and it's going to rest on your occipital bone, the midline part of the occipital bone. And in terms of shape, it's going to be conical in shape, and it's also going to be 3 centimeters in length, making it the longest part of our brainstem. Then since the continuation of the spinal cord, we're also going to have an anterior median fissure that will divide the medulla into the pyramids and the olives, which I'm going to show in a picture shortly. Then we also have cranial nerves that are going to be attached on the medulla. That is the last 4 cranial nerves, also referred to as the lowest cranial nerves. Then we also have the inferior cerebellar peduncle being more laterally. Then on the dorsal surface, when I then project the picture, I'm going to show an open part and a closed part. The lowest part is going to be the closed part where we don't have the 4th ventricle. That's where you're going to see the central canal continuing into the spinal cord. Then we're going to have the rostral part being the open part where we have the floor of the 4th ventricle as well as the 4th ventricle itself. So I'll then show you the pictures now. So this is the ventral surface of the medulla, and the green part here is going to be our medulla. So this region here is going to be the anterior median fissure. Then we're going to have the 2 bulges on either side, which are going to be the pyramids. And this is where we'll be having the corticospinal tract lying underneath, hence the term pyramidal tract. Then just lateral to the pyramids, we're going to have the olives. So this is the olive for the right, and that's the olive for the left. And between the pyramid and your olive, you're going to have cranial nerve number 12, which is the hypoglossal nerve. So it actually imagines as about 6 to 12 rootlets that then join to form a hypoglossal nerve. Then beyond the olive, we're going to have the inferior cerebellar peduncle, which I'll show on sections. And that region between the olive and the peduncle laterally, we're going to have the last part of the last 4 cranial nerves, which is cranial nerve number 9, also pharyngeal, cranial nerve number 10, the vagus. Then you also have cranial nerve number 11, but specifically the cranial part of the accessory nerve. Then, when you then go to the dorsal aspect, remember we say the dorsal aspect we have an open part and we have a closed part. So this is going to be your closed part. Then this is going to be the open part. Right. It's referred to as the open part because usually when we do dissections, you find that when you remove the cerebellum, it's very easy to remove the roof of the 4th ventricle, but it remains open and bare. Right. So this here is our closed part, and we're going to have certain eminences which are going to be as a result of underlying structures that I'm going to show when we do the internal features. So we have a posterior median sulcus here. So I'll use one side. So going to the right, we have what we call the gracile tubercle. Then we have the cuneate tubercle. Then we have the tuberculum cinereum. So to make things make more sense and simplify it, when we look at the internal features, I'll show you the nuclei that you have on the dorsal aspect, which is going to be the gracile nucleus, the cuneate nucleus. Then you also have the spinal trigeminal nucleus being more lateral. So as a result of those underlying structures and their respective fasciculi, we have these bulges here. So we have more medially, we have the gracile, then just lateral to it there is the cuneate, then more laterally there is also going to be the tuberculum cinereum, right? Then this here is going to be the floor of the fourth ventricle, the open part, and this bit here is going to be our orbix, right? And I'm not going to describe much of it because of time, but something that I would want you guys to notice is the arrangement of these different trigones here. So when you look at the brainstem, going back to developmental anatomy, the way the nuclei are arranged is that we have vertical columns of nuclei where the more medial ones are going to be motor, then the more lateral ones, which are going to be the ala ones, they're going to be sensory. So when you look at an example that I'd love to use for this specific lecture, we have a hypoglossal trigone here, which is going to be as a result of the underlying hypoglossal nucleus, which I'm going to show that is also going to be medial. Then, okay, so having looked at a bit of the external features, when putting them now, we're going to do the internal features. I would have loved to do this at 4 different section levels, but to make it simple, we can look at it from 3 different sections. So the first section that we can look at is the one for the pyramidal decussation, which is going to be the lowest part of the medulla. Then after that, we can go to midway up the medulla and look at the level of the decussation of the medial and this guy, which is going to be the sensory decussation. Then we can also then look at the level of the olives, which is going to be on the rostral medulla. Right. Okay. So this is a picture that is showing us the level of decussation of the pyramids. And to make it a bit more simplified, if you remember the structure of the spinal cord, how you have the ventral horns and the dorsal horns, as well as the white matter, that same structure is going to be noticed in this kind of specimens. So, right. So this here, this is going to be where we're going to have the pyramidal decussation. So if you look at a section that is continuing from the spinal cord going into the medulla, this will simply represent the continuation of your ventral three horns. Then, if you go to the dorsal aspect, remember I said on the outside you're going to have eminences as a result of underlying nuclei as well as their fasciculi. So the one that is going to be more medial, we're going to have the gracile nucleus and its fasciculus in that region. Then you have the cuneate nucleus and its fasciculus in this region. Then more lateral, remember we said there's going to be a tuberculum cinereum. Okay. So you're going to have the spinal tract and the nucleus of the trigeminal nerve in this region. This will represent a continuation of the dorsal gray horns from the spinal cord. Remember we said this will be a continuation of the dorsal gray horns. Right. So to talk a bit about this, your pyramidal decussation is where we have most of your corticospinal fibers decussating within the medulla. Not all of them will actually decussate, and most of them, about 85%, will decussate in this region. Right. Then looking at another level, this is going to be decussation at the level of your sensory decussation of the medial lemniscus halfway up the medulla. So these are still going to be the pyramids. Right? There is no decussation yet because remember the decussation is going to be in the lower medulla. With this kind of machine that I'm using, we're going up. Right? Then, so now we're going to have the decussation of the medial lemniscus. So remember I said we have the gracile nucleus in this region as well as the cuneate nucleus. So we're going to have a curvy nature of fibers, which we call internal arcuate fibers, that are going to move from these two nuclei, and they decussate as the medial lemniscal decussation, hence the term dorsal column, medial, and meniscus pathways, because they will be coming from the dorsal column of the spinal cord, and they will be carrying sensations of fine touch, discriminative touch, proprioception, and the likes. Right? Then also introducing something else. In this region here, we're going to have the reticular formation. For the purpose of this short lecture, I'm just going to give emphasis on a special nucleus that we have in this region, which is going to be the nucleus ambiguous. Ambiguous because it's not specific to one cranial nerve as the other nuclei are. So this nucleus ambiguous will actually serve cranial nerve number 9, 10, and 11. Meaning to say that when we have lesions in the medulla, then you can tell that this is a bit lateral. We're going to have problems with the nucleus ambiguous. Then in this region here we have the central gray matter. It's a bit more medial, and that's where we're going to have the dorsal nucleus of the vagus as well as the hypoglossal nucleus. Then this is at the level of the inferior olives, and I'll just love to show one of the nuclei that are going to be associated with the cerebellum. So these are going to be medullary nuclei that are going to work in conjunction with the cerebellum. So we have this crumpled case-like structure, which is going to be the inferior olivary nucleus, and this is going to have its hilum facing medially. Next. All right. Then for the blood supply of the medulla, we have arteries that are basically part of the posterior circulation of the brain. So that's going to be vertebral arteries and the subsequent branches that are going to come off it. So we're going to have the two vertebrals forming the basilar artery, which is this one. So these are the two vertebrals. Then we also have the spinal arteries coming off the vertebral, as well as the cerebellar arteries. All right. Then we have what we call medial medullary syndrome, which is going to be a lesion that is going to be as a result of maybe a stroke. For example, the anterior spinal artery, which will supply the medialmost parts of the medulla, and it's going to present with ipsilateral problems as well as contralateral problems. But to get the gist of it, you just need to remember like the organization where we say the motor cranial nerves are going to be a bit medial, and what's going to be sensory is going to be lateral. So in terms of ipsilateral paralysis, you're going to have paralysis of the tongue on the same side. Then in terms of, because of the hypoglossal nucleus, then in terms of contralateral, we're going to have hemiplegia as well as loss of touch and other senses. The hemiplegia being due to affecting your corticospinal fibers. Then the loss of touch is due to affecting your dorsal column pathway, right? Then the sensations of the face are going to be spared because the spinal trigeminal nucleus is not going to be affected, right? Then I have this small, okay, not so sure if we're going to do it, but this is where we have the tongue that is going to deviate to the left side. So will you be able to then localize the lesion? And remember I said the nucleus for the hypoglossal nerve which supplies the tongue is going to be medial. So since it's going to be medial, can you guys try show you understand it?
Sure, you got only 30 seconds to do it.
Are you ready?
Yes, very ready.
Okay, you can raise your hand to make it. Oh. So remember we said that the tongue will actually deviate to the side with the lesion. Then what's going to be affected is going to be the medial part, because that's where we say we have the central gray matter when we have the nucleus. Right? Then we also then have lateral medullary syndrome, which has general symptoms which I won't go much on. But when you then look at the ipsilateral and the contralateral signs, more importantly, we're going to have nystagmus. If it's going to be ipsilateral, there's going to be a rotational component for the nystagmus versus the horizontal component that is associated with the contralateral problems. I hadn't described the vestibular nuclei that you also have those are the ones that are going to be ascribed to this. Then remember I talked about the nucleus ambiguous. So for overload deviation and problems with the palate and the larynx and the pharynx, this is associated with the nucleus ambiguous because that's where you have cranial nerve 9, 10, and 11, which you subsequently form your pharyngeal plexus. So to end, I had a thing page here, which I think we're going to do, but I'm done. Thank you.